the vast majority of healthcare consumers still think that their PCP has to refer them to physical therapy. We're not changing that by direct access, but we think we have. And this community and this profession, I think, believes that we are getting a high enough volume of patients, or that we're capturing many of them. We haven't scratched the surface of the number of individuals that we could be managing. Kick it.
Welcome to Strata Stories. My name is Thomas Schreiber. I'm the Director of Marketing here at Strata PT. Strata PT combines your EMR and billing into one automated system to increase revenue and achieve a 99.99% reimbursement rate for physical, occupational, and speech therapy clinics. On today's episode, Paul Singh, the CEO of Strata PT, talks with Dana Strauss, a DPT and policy health expert. Paul and Dana discuss the need for stronger collaboration and shared incentives between primary care and physical therapists, ongoing consumer confusion about direct access and the continued reliance on PCP referrals, and lastly, how PTs can stay informed on policy changes and emerging healthcare trends. If you'd like to learn more about Strata PT and see how our EMR and billing works, head over to stratapt.com to book a demo. Now, without further delay, here's today's episode.
We've got an inauguration happening, and change is afoot here in DC. But also, the thing that I think it'd be kind of cool to talk about your email that went out this week. But if you're like fired up about something else, let's go a different direction.
We could do that. Yeah.
You talked so your email subject line was the primary care upgrade. And I'm not going to do you any justice by like paraphrasing it, but I read it and I was like, this makes a ton of sense. But just for anybody that hasn't read it yet, and we'll put a link to it in the show notes, but can you just talk about that? Like for anybody that hasn't read your newsletter yet, what was the primary care upgrade piece that you wrote?
Well, when I saw the APTA put out that report that unfortunately only members of the APTA can read, so I wasn't able to upload it to the newsletter. But when I read that, I thought, okay, and I'll explain what it's about. They got it about 70% right, but there's a whole bunch that I wish had been included, and so I want to talk about that. So essentially, the APTA looked at physicians' attitudes about physical therapy, and then also the way physicians perceive that consumers think about physical therapy. And what it said essentially was they think a little bit more highly of physical therapists than they do orthopedic surgeons, and a little bit higher about orthopedic surgeons than they do about OTs, and then chiropractors, further down the totem pole. And, at the end, the summation, the conclusion of the APTA was, okay, what can we do to make it better, the relationship between PCPs and PTs? And it's so important that we do that. Preaching to the choir, right? I talk about this a lot. And this, developing a synergistic relationship and improving communication. But all of those things that are going to make it better require incentives. And when you talk about, I've heard you speak about this many times listening to your podcast, this is how business works, right? This is how professionals think about things. There have to be incentives for something to change. And right now, there's not great incentives for physicians to communicate with PTs. There's not great incentives for PTs to communicate back. And frankly, PTs don't have the time, and they don't have enough reimbursement to make the time. And the only real solution is value-based care. It goes back to value-based care. The only way we're going to get to that place. And as I've made this argument also many times before, to me, we need a groundswell of support in the physical therapy community to also, even though it's hard to stomach and swallow, I know for many therapists, we need to be embedded in primary care practices. It's not going to be for everyone, but if we want to be carried along with primary care as it's growing, and as more reimbursement is going to primary care, and as the alternative payment models focus on primary care, and we can do so much more than PCPs even know we can do. There's no other way except in person, doing warm handoffs, discussing patients real time. There's no other way to do it in my mind. And I will, absolutely die on that cross. That until we do that, and that's part of what the profession is going to believe, we're going to be stuck essentially spinning, not the cash-based stuff. That's a separate topic, right? So let me stop there and see what your reactions were. And
Well, one of the things one of the things I love about, your like talking with you is that you're able to take very complex topics and explain them in a way where I don't feel like an idiot. And I think that's a lot of the feedback that I've gotten from the episodes we've shared with you or done with you as well. So, but um, I have I don't know how to like respond to what you're saying, so I have a question, and I feel like an idiot asking it, but I don't know where else to go with this. So, I live in Virginia, and I imagine my primary care doctor in the facility he's at is just like everywhere else. And as you're talking about this, when I think about it, in that, and so here in Virginia, like everywhere else, like you've got health systems that take over, right? So, like when I first started going to him 20 years ago, he was an independent practitioner, and then Inova Healthcare is like the big thing here in Virginia, and they rolled everybody up, right? And the thing is, like, if I were to drive out here, his office is like 10 minutes from me now. And so when I go out there and it's like, hey, man, I want to get my annual physical, or hey, I want to do whatever. The interesting thing to me, and again, I feel like an idiot asking the question because I don't know how to articulate it, but if I were to go in there, and I bet you if I were to like line up all the people that work in that office against the wall and like then ask them what they all do, you got front desk people, you got the doctors, you got the nurses. There's actually like the people that like draw the blood and stuff like that. Phlebotomists. Yeah, that's such a hard word to say. But I don't think I've ever seen like, that sort of like, why isn't a PT in there? And I don't know if that's like a dumb question to ask, but I, it's like, why isn't that? Because, I think about it from the perspective of, if they had a PT there, then I could get referred across the hallway or vice versa, but they don't. Instead, like, and this is a direct access state, of course, but at the same time, like, even if they do want to refer me to somebody, they're like, here's a list of 12, go away. But why is that? I mean, is it like, is there not enough patient volume maybe? I mean, I don't know. Like it seems like a
it's culture and incentive. So for a primary care physician, right? Their bread and butter, unless they're in value based care relationships, is volume of visits. So for them, right, they don't have a great incentive as they're structured in a typical practice, kind of the old fashioned practice, to embed a PT because they want, as they should for their business model in fee for service, they want to see those patients first. They don't have a great reason to have a therapist in house. Yes, for the good of the good of their hearts, they want their patients who they think they would benefit from PT. They want them to go. They'll give them the prescription. They'll spend a minute because that's about all the time they have. They'll spend about a minute talking about it, and then they're going to cross their fingers, hope they go. And nothing negative is going to happen to them or their business if they don't. But if, right, in fee for service, if we start to think, the public starts to think about, we go to physical therapists when we have pain, when we have trouble with balance, when we need to use a walker, when we have headaches, when we have shoulder pain. There's a whole lot that's in scope for PTs. And PCPs don't want to give up those visits evaluating those patients. Those E&M codes are part of their volume. And it's somewhere around 35% probably patients that could skip the PCP and go right to the PT. But then you take, right, and I wrote about this a little bit there and other times. If you take a practice that said, okay, we're going to take all of the delegated risk from the payer, the payer is going to give practice XYZ all of the dollars, and you are going to be responsible for every dollar that's spent, right? Now they don't care about the billing because they don't want more fee for service billing. They want to manage patients in the best way possible, and they're not making more money if they bill more. The way they're going to make money in that, non fee for service capitated, not the old fashioned capitated where it's just you're paying them up front, but capitated and then earning money on the back end for saving dollars by preventing hospitalizations, not by using less therapy, right? They want more therapy. They want more mental health. They want more social work intervention. They want people safe, right? That's a whole different paradigm. And PTs should and can be bearing the brunt of those workforce challenges, doing the interventions that will prevent things like avoidable orthopedic visits and avoidable MRIs and surgeries and injections and all of those things that start to skyrocket prices. PTs and OTs, frankly, are the perfect solution to bring in house in a PCP practice. And it'll shift the paradigm when physicians with that new incentive structure, when they see what can happen, it will change the culture.
And you can take a pass on this question if you
No,
like,
I don't
but
take a pass. It's okay.
I love it. You don't even know the question yet. But okay, so I'm an optimist. You know, I feel like you kind of have to be that way, because like cynicism and all these other things are just, I don't know, it's just infuriating. Um, and so like, what would it take? So for example, here I'll just keep using Virginia as an example because it's the only one I know here. Inova Healthcare is so big. I mean, I could probably go Google how big they are, but they're just so big that, to your point, the incentives are what they are. And, you know, most of the executives, I would imagine, are good people, but really playing not to lose their careers, not to lose their promotions, not to lose their bonuses. It's just rational human behavior. It is what it is. Is there like an, is here's the question. Is there an opportunity maybe for like a, let's say a PT that happens to be best friends with a primary care physician to kind of say, "Hey, you know what? Let's cohabitate in the same office." Okay, so you're nodding like it's like because it's really like, you know, and I'm oversimplifying it here, but you know the businesses are relatively similar. You got to get credentialed, you got to, you know, do all that jazz. You got to go get your referral sources for patients or do your direct marketing and all those things. I'm oversimplifying, of course, but in other words, like it is possible. It sounds like you're already saying yes. Like it would, like if an entrepreneurial PT was like, you know, having dinner with their friend who's a primary care. Right now, the extent of those conversations, if they have happen at all, are probably about referral relationships where it's like, hey, can you put me on the PDF that you give out or whatever? But it could go one step further theoretically or hypothetically, it could go one step further to say, hey, I want to put one of my PTs in your one of your offices and get them, you know, I, that just seems like too simple though. I wonder why. Maybe this is the rhetorical question, I suppose, unless you want to take a stab at it. It's like, I wonder why that hasn't happened yet.
It's again, it's just the physician and the culture of going to your physician first, which was in that piece. It explained that consumers, number one, don't care a rat's you know what about direct access. It means nothing to them, and that the vast majority of healthcare consumers still think that their PCP has to refer them to physical therapy. We're not changing that by direct access, but we think we have. And this community and this profession, I think, believes that we are getting, you know, a high enough volume of patients or that we're capturing many of them. We haven't scratched the surface of the number of individuals that we could be managing if that relationship between PCP and PT and OT were stronger, number one. Number two, that physician who would bring a therapist in house and fee for service is going to first do the math and make sure in their mind or try to figure out, if I do this, is this going to reduce my own E&M visits? Because, you know, patients will start to realize that they can just book with the PT and skirt me. If it's going to reduce their E&M visits and it's 30%, let's say, anything that a PT could and is appropriate to see first, why would they do that? The best chance is to, yes, where you have a relationship where a physician is considering going into a value based care relationship, helping to support that from the beginning as a partner in that exercise. New physicians who don't yet have, like, you know, aren't so used to the system that they're going to be thinking, oh, this could potentially impact my fee for service volume. And to go back to the ANOVA, because I'm glad you brought that up, where this topic overlaps with the site neutral payment topic. So for listeners, let me just cover real quickly site neutral payments. So right now, right, hospital outpatient practices, anything that is owned by the health system, as long as that relationship, that purchase of an outpatient physician practice was before a certain year, which I won't remember, there is the billing is the same as the billing as would be in the hospital. This is why hospitals and health systems went out and bought practices like crazy, right? Now, uh, there's no incentive to go into full risk if you're not a great incentive if you're one of those practices, right? You are definitely making out better if you're a health system owned physician practice by continuing the fee for service billing and maybe getting a little bit benefit on the back end with a little bit of shared savings and risk. But we're in a new world where we have a populist Republican sentiment who is ready to act on site neutral payments. And this is not, I can't make any predictions, but it is absolutely something that is being discussed regularly now more than ever because the political paradigm is changing and because there is a lot of money stuck in site neutral payments, right? Hundreds of billions, some estimate trillions of dollars. So when we start to separate health systems from physician practices, and physician practices are functioning not just as referral sources to specialists for that health system, because that's when you own a PCP practice as a health system, you want every possible referral to specialists. That's where they're making the bulk of their dollars. When you divorce the health system dollars from the physician practices and you force that separation, now everything changes, right? And the PCPs start to become their own business people again. And so where we're seeing full risk is where PCPs and team-based primary care are not owned by hospitals. They have the incentive to sometimes double and more their typical salary.
And maybe I'm not connecting the dots. That's counterintuitive to what I thought you were going to say. Yeah. So let me make sure I heard what you just said there at the end. You said that the risk is greater for the smaller practice. Is that what you just said?
The smaller practice that's independent is willing and it makes sense for them to go into full risk relationships with insurance
Okay.
companies.
Yeah. Yep.
Payers, I should say.
Got it. Yeah.
Right.
Yep.
Because then not only is there no longer the incentive to do a lot of referrals to specialists and, crank out fee for service volume, there's also the incentive to reduce hospitalizations. And when a health system owns the physician practices, they don't want reduction of admissions to the hospital. They have to fill their heads in beds. Hospitals are the most fee for service driven and any of the inpatient settings. So once you separate those things, which hasn't been able to happen because of the political environment, now that site neutral payments are bubbling up and we're going to start chipping away at that because the federal government and those that are coming into power need money for what they want to do. Site neutral payments now are becoming a reality that we would fully expect to see chipping away. And then the paradigm is now ripe for more independent PCPs who want to make more money. And right now they're making much less than specialists, and their value, just like therapists, which I talked about in my newsletter article, their value to the health system, and I mean the health system writ large, right? Their value to healthcare delivery and to healthcare spend is so much higher than what they're making in fee for service. They reduce spend dramatically. Advanced primary care reduces hospitalizations by 40 to 50% in full risk. Think about how monumental that is. People aren't ignoring that. And physicians that are independent and are ready to take that leap, if I'm a PT in that community, I want to be part of that because they're the ones bringing in more money. And they're going to be making strategic decisions using data, who they want to partner with, that's going to help them keep people out of the hospital, who is going to have excellent access to care, whether that's embedded therapists and or the practices around them. It's impossible for me to imagine a scenario where what I'm suggesting is incorrect. I'm also watching it play out in front of me now. I'm seeing advanced primary care groups absolutely wildly successful at reducing other spend. We want to be on the side as therapists of joining in this crusade to prevent people from being in the hospital. Why wouldn't we? Right? Why wouldn't we as a profession want to do that? It's for our mission of what we do, to realize the value and really demonstrate and be able to benefit from that value. Right? Does that make more sense?
It does. And again, I love learning from you, right? Because well, anyway, it's interesting. I come from venture capital, and in the world, and even then before that, I was an operator, just like I am now. I've just always been an operator, and it's interesting. Like my mind, no matter what we talk about, and even in this topic, goes back to like, okay, what is all we got to do? Is all we got to do. I hate that phrase, but whatever. Um, like anybody can tell us the 87 ways something can't go right, and then it's very rare and refreshing to like find people that are like, okay, what is the one thing that has to go right? Because maybe that's like a fun conversation. And I think as you were talking about that, what I'm kind of thinking about is like, and this is actually related to the speaker submission that I mentioned to you in the pre-show here a little bit ago, is that I'm going to show all these. I'm going to talk about like sort of the longer I spend in physical therapy, the more I can't help but continue to confirm that I think that there's more in parallel, there's more similarities between brick and mortar physical therapy practices and the tech companies that we all know and maybe love and hate sometimes, right? In other words, like if we were to go find these tech companies out there right now, some of these big ones, small ones, whatever they are, doesn't matter. They're all going to say basically the same thing. They see themselves as customer acquisition engines. They provide whatever it is they sell. Like, you know, uh, Amazon looks at itself as like a customer acquisition engine, and they just got to figure out how to get you in to buy the first thing. And they give you so much convenience that you want to spend more money there. It's frictionless, it's easy, and all that. Um, and the idea that I can't help but shake as I think more about this is like, you know, and I'll just throw Inova under the bus because they're not here to defend themselves. Inova has there's no incentive. I mean, they like to improve. In other words, here in Virginia, we're at a point now in 2025 where like they just sort of gobble up every independent, practice anyway. That's just the model. I'm not trying to give them a hard time. That is what it is. Any change that we could try to do there, requires getting through a bunch of gatekeepers that all have their own rational reasons for why things don't need to change or whatever. And my mind just naturally goes back to like, and this is going to sound, you can totally laugh at me on this. Like, I go back to this idea of like, I didn't even know what direct access was until I got into this business. Like, I didn't know that. Like, no. And I feel like I'm not the smartest guy in the world, but I think I feel like I kind of know some stuff. I didn't know that I could go to a PT without a referral. And I'm thinking to myself, as a patient, just as a normal consumer, I'm thinking to myself, all those years, like I told you in the pre-show, like I run a lot, so statistically I got to go see a PT twice a year. I'm just thinking about all those years. I've been running since high school. All those years, every time I got hurt twice a year, I went to my primary care thinking I needed a referral. Well, that took forever. The appointments aren't available same day. Well, I waited 3 weeks. Then I get a referral. I get this like crappy PDF that clearly has been copied so many times that it's like hard to read with like 12. Like I just wasted so much time as a consumer, as a person, as an individual. And it's infuriating actually. And this is going to sound so elementary. You can totally laugh at me. Like I just I think about like there's a how there's like realtors everywhere. I'm gonna get punched in the face by realtors now. But the thing is, even individual realtors market themselves better than most PT practices do today. Like, what do they do right now? Like, I think about just like, so here I am in Virginia, and it's the beginning of the school year. It's January when we're recording this. And Kevin, the guy that happens to live in this neighborhood and just happens to be the guy, I just know in my mind that he's going to send the high school football calendar as a magnet with Kevin's face, and you just throw it on the side of the fridge. And, in the summer, he sends like the poison control thing, and it's got Kevin's face. He's not doing that. Like, that's not unique to him. That's the playbook that whatever broker he works at just gives him. And he does it. And like, he's not unique. I don't think Kevin listens to this podcast, but the point is, realtors market themselves. I mean, hell, dentists market themselves But I can't think of the last time I ever got a piece of mail in, or any education about it. So this is maybe more of a rant than anything else. But my mind, as I was listening to you talk about all that, just kind of goes back to this idea of like, you know, what would it take to kind of like, actually, let me just say this a different way. If if we could inspire even one independent practice owner to just embrace this idea that if they were to see themselves as a local marketing company that provides health care or better health outcomes, or if we could convince even one of these practice owners to look at themselves as a patient acquisition engine that happens to provide, that sounds like a little bit of wordsmithing or whatever, but I am convinced that that subtle shift in how you think about your practice would change everything you do, um, in your practice. Cause like, I don't know. I can't remember if we hit the record button before I said this, but again, I didn't, I admit fully, like, I feel like I'm not unique in the sense of as a average patient, I don't check my EOBs. Like when I go to the doctor, just, I pay my copay, and if something goes wrong, I get that scary letter that says you owe $17 or whatever. But by and large, when the EOB email notification comes in from Aetna or whatever, I don't look at it. Now I do. Now I do, and I'm like, huh. Like and I said this to you in the pre-show. Like if I go to my PT twice a year for a running injury or whatever, typically that plan of care is 5 to 6 visits. And Aetna, whatever the contract, I don't know what the contracted rates are, but on the EOB, I can see they're paying about 120 bucks per visit. So I'm not a genius, but I know 10 visits per year times 100 is $1,000. I'm worth $1,000. And like, I know I'm like ranting here, but think about the tech world I come from. Like let's use Netflix as an example. I don't even know what we pay for Netflix, but let's just assume for the sake of discussion, it's 20 bucks. Netflix has built a multi-billion-dollar massive business off of customers like me who only pay, let's just for the sake of discussion, call it $20 a month, 20 times 12, 240. And even at these small numbers, they can build these multi-billion-dollar massive plays. And I just think to myself, like, why aren't I mean, like, if I'm worth $1,000, why haven't I ever heard from my PT again? Like, I've been going to the same guy literally since high school, right? And I can't think of one time where I ever got a piece of mail or a magnet or whatever. Like, he knows I'm coming back, like statistically, but
Of
his
course.
practice doesn't see itself as a marketing company. It just
Yeah.
assumes that I'm going to show up.
Which is a mistake. Which is a mistake because you're you. And there are people like you. And then there's the rest of the public that, largely doesn't, as much as we want them to, does not view physical therapy as something that I go to a couple of times a year to check up. Arguably, it would be the best thing for them. And where we've seen things like annual wellness visits be not just a revenue source in fee for service, because it's a significant reimbursement, the annual wellness visit for physicians, but the physical therapist, occupational therapist, we should be a part of that idea that this should be something that's looked at annually. It's there's definitely a market for it. Tap into it.
It's okay. So I'm going to embarrass myself a little bit, but what's new? I feel like I do it twice a day, 3 times a day anyway. But the thing is, I fully admit that the only reason I ever really got interested in healthcare, 5 or 6 years ago, was when I stumbled across durable medical equipment. And I was like, oh, I just never noticed like this is a little bit of a story. So it's like, I remember it's probably around 2020. My wife and I were expecting, my third child. And, one day I pulled a package in from the door, and I was like, oh, what's that? And she's like, oh, it's a breast pump. And I was like, oh, I thought we had a couple of those already. It's child number 3. And she's like, oh, look, every time we get pregnant, I just go get another free one. They're free. And I was like, wait, that's free? And I Googled it, and I'm like, okay, I could buy this from Walmart for 275 bucks or whatever. Why? How's this free? Well, here we go. I log into the, and I'm like, honey, what did you do to get this? She's like, you just have to send the doctor has to approve that this is a viable pregnancy. And then you just send them a copy of your insurance card. So now I'm like on the hunt. I go log into Aetna. I open the EOB, and I'm like, holy cow, these guys paid $800 to Aeroflow or whoever it was. And that's how I stumbled into this whole thing, right? Now, here's the embarrassing part. If we time traveled back 3 years, 5 years, before I even got deeply involved in Strata PT, if you asked me what physical therapy was, I don't think I could really tell you. I just thought it was like something I'd go to. I could tell you, I go see a physical therapist like when my knee hurts. But so I thought of it as like a reactionary thing. I got to go through my primary care. He refers me. And I just thought it's like, you just go see your physical therapist. And now, as I spend more time, though, with practice owners and things like that, it's really fascinating. Like, it's changed my entire perception. I remember when I was at PPS or whatever, I was shooting the breeze with, there was like a PT, obviously at PPS that was hanging out there, and we were having dinner or whatever. And somehow the conversation came up of like, we were talking about, we're both dads, and somehow the conversation came up, and I said something in passing where I was like, you know, I I hope that when I'm 45 or 50, like I want to be able to keep up with my kids. I want to be able to pick them up without grunting. My dad was like a strong dude, but granddads all grunted picking you up and whatever. And I was like, I just somehow in conversation, this idea came up. And what was interesting was, as a PT, he's like, "Oh man, look, there's exercises you can do for this." And he was like, I don't know, it just changed over time, my opinion of, I guess where I'm going with this is, the business of physical therapy has a marketing problem, particularly at the individual, outpatient setting kind of model. Like, I think that's the biggest opportunity here. Like, the other thing is the parallels. Nobody's going to believe me on this, but, again, I come from venture capital. In the venture capital world, it's a little stratified, meaning you have these massive firms that control hundreds of billions of dollars. Then you have this like sort of middle layer of, they all have different marketing terms, but they might manage $2 to $10 billion. And then at the bottom layer, you have what we call angels. These are individuals, millions of individuals that can invest. They don't have to register with the SEC because they don't manage people's money. And one of the things I've talked about, ad nauseum for 10, 15 years in the industry is that, in the venture industry, is this idea that everybody thinks that the big players will shape the future of technology and everything. But the data doesn't support it. And actually, the thing I say a lot is this idea that the individual angel investor, the bottom layer that nobody pays attention to, they actually, if they could just organize themselves a little loosely, they represent the biggest danger to these larger upstream venture capitalists. Because, for example, why would you even need to go to the big, massive VC and go kiss the ring if you could pull the same money from 100 wealthy individuals? So I'll just carry that over to private practice. Inova is up here. The big health systems are up here. And then probably like some multi-site, clinic operators, the ones that like have, let's just call them like the franchises, the physicals of the world or whatever. They're probably like right here. And then you got, depending on who you talk to, 20 or 30,000 outpatient practices that are down here. And the biggest opportunity, like I can't change Inova. I don't have the patience or the interest to do it. I mean, you might, but I just, but like that bottom layer, and I don't say bottom in like a negative connotation, that these are the hungriest people down here. And I think even if we could convince one of them to look at themselves as like a marketing company. Anyway, I'm sorry, I'm like ranting on this. One of the other things that you are so good at articulating is policy and like what it really means for practice owners. And you were starting to talk a little bit about this. And I want to like make sure I give you some time to talk about this if you're interested. Is like, we've got a new administration coming in. Doesn't matter if anybody's red, blue, purple, it doesn't matter. The point is, different people probably seeing the world slightly different than the previous administration. And so, I think in the pre-show, you had sent me a couple of topics that on this you could talk about, like you were talking about like ACOs and sort of the changes there. I think you already touched on sort of the inevitable growth of MA and risk and fee. What, like, you've met a couple practice owners, like, I mean, you've met a lot, right? But what should people be keeping an eye on over the next couple months and quarters as it relates to outpatient physical therapy?
Before I answer that, go back to one thing that you said that I think is just be helpful to comment on. I think the what we overlook, because the therapy community getting too in the weeds, is consumers, many of them, and nothing is a generalization to all, but many consumers think about physical therapy as a burdensome commitment and a lot of active work that many consumers don't see themselves fitting into, and need to know upfront in the whatever the marketing is, that there is a solution and that they will understand what that solution is immediately. Like as soon as they interact, there are still, and this is not to probably a lot of your listeners, it's these large practices, they're still cranking out 3 times a week times 12 weeks. You would think that would be old, but it's still out and about, it's still there. People don't want that, they don't want it, and it's unfortunate that it is so, baked into fee for service. It's got to stop. It's not going to stop before fee for service is not predominant, but if it doesn't, you're still going to be fighting against this feeling that it's a burden and it's work, and there's so many things that have to go right for a patient to show up, right? To complete their plan of care. But anyway, I will leave that there. And I think it will be really good for your listeners to hear a little bit about what's on the horizon for health policy. A lot of this physician fee schedule stuff is going to be a next year thing, second half of the 119th Congress. They're more likely then to deal with things like how are we going to fix physician and other provider pay. That will probably marry into paying PCPs differently, thinking about how that might look different, how to put that into accountable care at the same time, and macro reform. So, I know many of your practices have to report MIPS. MIPS is kind of stinky in a lot of ways. It's not doing what they said it would do. These things are connected, and there's no appetite for it this year. This is going to be Trump tax cuts. This is going to be the border. This is going to be mandatory extensions that they have to act on. That's Congress. Let's step just for a moment to what we're hearing now about the administration. And by the administration, let's talk about Center for Medicare. So we know Center for Medicare and Medicaid Services is likely, as long as it gets confirmed, going to be Dr. Oz. He's very pro Medicare Advantage. And the growth statistics as of right now, just because people are, working people aging into Medicare, they're used to managed care, and they're opting more into MA than they are into fee for service, much higher rates, right? What we also know is, I'm not going to say his name yet because it's not official, but the person that's 99.9% likely to get the job as leading the Center for Medicare and Medicaid Innovation. He's a venture capitalist. He looks at the world very differently than the Innovation Center does now. And what we're very likely to see is something come back that I want you guys to hear it and decide if you're going to pay attention or not. Something called, we're likely to see come back, not 100%, but likely, the geographic direct contracting model. And there's a specific reason I want your listeners to hear about this, because it will affect you whether you like it or not. In this model, right, it's for fee-for-service beneficiaries, which is the bread and butter of a lot of practices. What Trump, the administration, rolled out but never carried through because Biden ended the model before it started, his administration. What this model does is it takes regions of the country apply, an entity, and leave that broad, an entity, very likely to be a lot of health plans, apply to Medicare to own the risk for a geographic region. And what that means is you don't need the providers in the area for the fee-for-service patients to belong to these risk-based entities. It's going to be owned passively by risk-bearing organizations whose job it is they're going to get all the dollars from Medicare, they're going to manage the care, and it's going to be very close to what you see in Medicare Advantage. You don't have prior auth because it's still fee for service Medicare, but you are going to have direct contracts between this entity that's going to own all the fee for service beneficiaries, responsibility for them. They're going to get into as many direct contracts with downstream providers as they can to incentivize upstream care. So if you're a practice, last time Philadelphia was one of the regions chosen. That means every fee for service beneficiary is going to be attributed to this entity that's responsible for the dollars, right? If I'm a PT practice and every one of the docs in my community is now in a contract where they're going to earn more if they can prevent hospitalizations and save money, right? If I'm a practice owner in that area, I certainly want to know and to be at the table also getting into these contracts where there's going to be really strong referral relationships. If you're responsible and your livelihood is going to depend on whether or not you're successful, you will choose the practices to refer to that are going to help you be successful. So know about this. If you see it come out and we know what areas, decide to apply and what get accepted, assuming it looks like it did before, right? There's some assumptions we're making here. But if it comes out, please, therapists, please pay attention to it and think about how to participate.
Well, on that note, like when you say please pay attention, how will they know that it's coming? And I know that sounds like a dumb question, but
No.
that's something that I hear behind the scenes. Like nobody wants to look dumb, so nobody ever says publicly like, "How do we find out?" Right? So I'll be the guy.
Yeah, no, just subscribe to the newsletters in CMS.gov. That's it. CMMI's newsletters, right? So the innovation, there's so many subscriptions. So be broad enough to capture it, but not so much that you're reading about the intricacies of every little site of care. But definitely, right, any of the innovation center models, you want to be on their newsletters, CMS. They're putting out blogs about this. Well, not this administration's not putting out blogs, but there's a lot of blogs coming out right now that it's great to pay attention to. You can learn about a lot of this stuff just by subscribing.
I love it. Somehow you just make these complex topics easy to digest, and maybe anyway. I absolutely love it. Well, I appreciate you kind of getting me back on the show here.
Yeah,
Um,
always
let's
fun. I love it.
I love it. And your newsletter, by the way, first of all, I feel like it gets better and better every week. I don't know that you're doing it weekly or whatever, but anyway, the point is like as it keeps coming out, I just feel like it's just punchier, and it's not that it's never been bad, right? There's a compliment poorly buried in this, but
Takes time, and I'm still working at it.
well, you're doing something right. I love it. I think it's so great. So we'll put a link to that in the show notes here. All right,
Thanks.
Dana, I appreciate you being here. Thank you so much.
Thanks for having me.
Thanks for listening to another episode of Strata Stories. Strata PT combines your EMR and billing into one automated system to increase revenue and achieve a 99.99% reimbursement rate for physical, occupational, and speech therapy clinics. If you'd like to learn more about Strata PT and see how our EMR and billing services work, head over to stratapt.com to book a demo.